being broken down. And eventually the cell runs out of one of these and the cell dies. So it's not ATP, it is ATP synthesis, yes, but to understand mitochondrial disease is to understand what the mitochondria are doing to the cell to make energy. And if we can, if the mitochondria are impaired, we can work with the mitochondria. We can treat the mitochondria in a way that they can make, that they won't damage the cell. Then things will be better. So the citrographic cycle, as I said, is located on these cristae. And this is a diagram some of you have seen. I did a webinar a while ago, and this is a diagram I made showing what might be going on in the mitochondria. I showed you acetyl-CoA before, and acetyl-CoA is converted into acetyl-carnitine, and then acetyl-carnitine is converted back into acetyl-CoA and acetate, and it's acetate that gets into the nucleus, and that's converted into acetyl-CoA. So the goal is to increase acetate in the cell, in the nucleus. And KAT6A, as you know, patients who have a deficiency, they have one normal function. And therefore, if one can increase the amount of acetyl-CoA that the KAT6A will use, then it can partially compensate for the deficiency of the KAT6A protein. And that's the primary goal of treatment. That's only one aspect. That's treating the primary defect. But it's not likely to be a complete cure of the biochemical abnormality, and that's why we have to look at the rest of biochemistry, understand how to support the cell as much as possible. And I should say what I believe carnitine is doing is enhancing the transfer of acetyl-CoA out of the mitochondria where it's made and into the cytoplasm. And that's converted into acetate and taken up into the nucleus. So this is where carnitine may be playing the role in the improvements that people have seen in their children who are taking carnitine. And what we know for sure right now is that carnitine is beneficial. And even though we don't have formal trials, I think the anecdotal experience has been quite striking in my experience as a mitochondrial specialist. And it also, the kind of changes that I've heard about are exactly what we see in treating certain groups of mitochondrial diseases, the primary abnormality in the electron transport chain. So the question is, what is an amino acid? An amino acid is a compound that is in protein. Protein is a string of amino acids, and when someone eats, the protein is broken down into the individual 20 amino acids that are in protein, taken up into the bloodstream, distributed to the body as needed. A lot of it goes into muscle, a lot of it goes into liver as a store, but some of it goes directly to the brain and other places. And what I'm trying to show here is that there, when some of you are aware that I asked that amino acids be obtained at 4 to 5 hours fasting. That's a special point of equilibrium where the blood levels tell us much more about what's going on in the mitochondria than if we do the blood right after meal or after overnight fasting. And what I'm trying to show here is that these values are, I'm going to skip that and go on. Explain better. So again, all of these amino acids will feed into the mitochondria. When the surge of protein from a meal is gone, then it's the mitochondria that determine the level of amino acids in the blood. So if we obtain the blood at 4 to 5 hours fasting, that we can interpret those levels as a sign of what's going on in the mitochondria. And what I was showing back here is that in complex 1 deficiency, this is a child with autism. In complex 1 deficiency, there is an increase in glycine and alanine, and it's about twofold increased here. And this might not be apparent if we're doing right after meal or after overnight fasting, but we can look at this profile. This profile by itself is essentially diagnostic of complex 1 deficiency or the equivalent thereof. So one can look at these ratios and draw very specific conclusions about mitochondrial function. And this is just to show you, I've already said it. I've done a lot of studies on autism, and it turns out that about half of autism is caused by mitochondrial abnormality. And there are 2 types of autism: regressive, where children are normal, they lose their skills, and non-regressive, where children are typically not normal from birth. And as I said, I'm looking, this is a method where this is what I have done for all of your blood samples, is if we obtain the blood and do a calculation on it, we can put a normal blood level to 1.0. So what this shows is in the children with autism, with regressive autism, that glycine and alanine are increased relative to the control. This is the control range here, the normal range, and that these are distinctly increased. And this allows one to, if the child has symptoms of autism, to just do an amino acid study rather than a muscle biopsy and determine if there's an abnormality in mitochondrial function. And this also, the combined increase in glycine and alanine also tells you how to treat the child. So this is the kind of information that we're looking for in KAT6A. I should also say, I'll come back to this later, that in KAT6, in some of the patients with autism, the tyrosine is low, and that is relevant. Tyrosine is a precursor of neurotransmitters, dopamine, norepinephrine, epinephrine. And if one is deficient in tyrosine, then neurotransmitters tend to be low, and I'll show you the consequence of that. This is a standard treatment for complex 1 deficiency that we do for mitochondrial autism. This is the kind of cocktail that Chloe started on, and it is designed to do 2 things. One is to augment the activity of complex 1, and the other one is to treat reactive oxygen species or free radicals. These form in conditions where, in certain types of mitochondrial problems, and they damage the mitochondria. And if the mitochondria are damaged by free radicals, then they don't work as well, and they make more free radicals. And that's why mitochondrial conditions often get worse with age. And if we can protect the mitochondria, first, we can stimulate the mitochondria to make more energy, and we can protect the mitochondria with these, and with this specific combination of antioxidants. And this works very well in most classical mitochondrial problems. And right now, all I'm convinced of is that carnosine in particular is beneficial, but we now have evidence that maybe the older children with KAT6A will eventually develop mitochondrial dysfunction, and therefore the question we have is whether treating with carnosine and pantothenic acid would prevent this damage to mitochondria over time. It's very specific. We can do tests that tell us very directly whether the mitochondria are damaged and if they need antioxidants. And in general, I have not seen that in the tests that have been done, except in a few older patients. So they have suspicion that it is getting worse with time, and that because there's such a clear benefit from harnessing catabolic acid, which works together, then there's a very real possibility that that alone will be adequate. There's no harm in giving the antioxidants, just along their pocketbook, but it's you don't have to give all those extra medicines. And that's one of the goals that I have in the next few years, is to set up some formal studies with children to be able to study this aspect and to determine whether through a formal treatment protocol we will monitor more frequently and do various extra studies to really answer the question of whether or not harnessing by itself is adequate. I'm not saying you shouldn't give antioxidants, and I had discussed things with Chloe's father on the phone a while ago, and it's quite clear that the immediate effect, the relatively rapid effect that one sees with the cocktail. So Chloe was given the cocktail, and it was, I think, more or less based on my recipe, and some benefits were seen within a few weeks. And the antioxidants take a minimum of 3 months to have that effect. So if we start the cocktail all at once, and the child gets better, we notice the carnitine at least that is working. And what we don't know is whether the antioxidants have an added benefit. And that's what we'll try to sort out. It's going to take more formal protocol studies, but that's the primary goal that I have as someone who works with mitochondria. Skip that. So here is, so I'm talking about amino acids. I'm going to give you now several instances where finding where the amino acid is critical to the treatment of a mitochondrial problem. And this is about methionine. And methionine is important because there has been some methionine deficiency in patients with KAT6A. And suffice to say that in certain types of mitochondrial problems, methionine is the critical deficiency. As the mitochondria become weaker and they draw more on the amino acid, some amino acid has to run out first, and it's usually methionine that runs out first. And methionine, there's not a lot of that in the diet, and there's not a lot in the body, and it's a very, very important compound in many things other than making protein. So this is a child with Leigh syndrome, which is a very severe type of mitochondrial problem, and it's fortunately treatable now. And I followed this patient for now 20 years. And when he was in his late teens, he started. All I can say is that he just wasn't as well as he should be. He's been well for many, many years, and he just started having more problems. I kept racking my brain on he's on a treatment that I know is working, and what could be going on. And just in reviewing his blood counts, what I found was that his red cells were getting larger. And a larger red cell is a sign of B12 deficiency or folate deficiency. So I measured his folate and B12, and they were high, not low. And yet he clearly had a rising MCV, and it really jumped up here, as you can see. This is the upper limit of normal, and it jumped above normal. And when I couldn't find that he had B12 or folate deficiency, I measured another compound, which many of the children have measured, called homocysteine. And if normally when there's a blood problem where the MCV, because of the size of the red cell, is going up, the homocysteine is high, but in this child, the homocysteine was low. The main source of homocysteine is methionine. So I put him on a relatively small amount of methionine. And I should say here, I forgot to mention, the methionine level in blood was not low. So here's 7 to 43 is the normal range, and it was 13, 22, and 20. But when I calculated it as relative to all the other amino acids in the blood, it was low. Not very low, but it was low. So this would never be picked up by a regular laboratory. One has to do a ratio study. And so I put him on a small amount of refining, and his NCD dropped like a stone. It dropped as fast as it possibly could, given the fact that red cells live for 4 months. So this is proof, and he got better clinically. That's the most important part. So that's proof that the refining deficiency was what was making him sick, not the fact that he had a mitochondrial problem caused the deficiency of the refining. That led to this is a young man who I have been treating for the past few years, and he has mitochondrial autism. So he was normal to a year's age, had an illness, lost skills. He actually had 2 episodes of losing skills, and he's sort of on the borderline between Asperger's and autism. And he has to be, he's not an independent child. And what I saw in his studies is that he had the usual things that we see, a high level of proline, glycine, and alanine in particular. And he also had a low level of tyrosine. Again, the tyrosine level itself was not low. At the ratio, it was 0.7, anything below 0.8 was low. So it was very subtle, but it was real. And so I decided to do that, to put him on a supplement of tyrosine. And this are some photographs of him before treatment, and it shows that he's not a very happy camper. And his mother says that he's just always, he's okay, he can take care of himself reasonably well, but he just never enjoys anything. And he really had mitochondrial dysfunction, and he also decided to put him on tyrosine. And that's the difference before and after. So this happened in December 2016. His mother's, he's just totally changed. He's outgoing, verbal, and his mother said that just this Christmas 2016 was the first time he enjoyed Christmas. And he's continued to do extremely well. And so again, the subtle deficiencies of amino acids are very important. And the reason it's hard, the reason it's not been recognized before, and the reason it's hard to detect is that if there is a deficiency of amino acid in the body, the liver tries to prop up the level in the blood to supply more to the rest of the body. So the blood can be low normal, but when you take it can be very low. So that's the reason that this again, not been found before, and we're finding, we found it first in a syndrome called Barth syndrome. Arginine was low, and that cured the heart disease in Barth syndrome. So now we're finding that the three primary victims, so to speak, in amino acid and mitochondrial dysfunction. One is arginine, and this it's just to say that tyrosine is a precursor for the neurotransmitters, and in effect what was going on is that he was deficient in the nerve cells in tyrosine. In fact, when I put him on tyrosine, and he got so much better, his tyrosine level didn't change. It stayed the same. All that extra tyrosine was going into the nerve cells, and it was really a tiny amount compared to it was only about 25 to 30% of daily average intake of tyrosine, but he was deficient and he needed it. Here's another young man I followed for many, many years. And all we knew is that he had a syndrome, and he had some signs of mitochondrial dysfunction, I tried treating him with a mitochondrial cocktail, and it helped a little bit, but it really did help a great deal. And he remained, he was fairly a young child, he was not doing very well as he got older. Found that he also had a deficiency of iron, as shown here. Again, the same kind of range with normal levels in the blood. And what we found out when we found that he had he had a abnormality. What we found out is similar to KAT6A. It's a histone modification, but it's methylation, and the methyl comes from methionine, methionine. And he has the same kind of abnormality. He has one copy that's normal and one copy that is abnormal. And so I put him on methionine, again, a very small amount. And that was the change in him. That's over a matter of just about 6 months, I think. Clearly he has trouble still. He's not an independent person, but he started telling his parents what he wanted, and he hadn't done that before. And he was very different. He put on a fair amount of weight. He started eating. I had to put him on a diet, to be sure. But just to show again, methionine deficiency is critical for him. And methionine, I'll show, comes in here. And the most common site of block in mitochondrial problems is in the first half of the citric acid cycle. So if there's a block here, and we can show this block by measuring these compounds in the blood. And then methionine and these 4 amino acids here become more important, and the mitochondria uses those to make energy. And methionine, even though all 4 can provide energy in this way, methionine gets picked on for reasons we don't understand. And that's the weakest link first. So in general, just to give you some idea of our resources for treating mitochondrial problems, and we've only really addressed the issue of carnitine and KAT6A. I have to first understand more about the metabolism in KAT6A to know how to approach it. But these are the kind of things that we do. Again, carnitine and you know about. Complex 1 is, in almost any kind of mitochondrial problem, complex 1 is has lower activity, and it happens to be the way carnitine works. It literally turns on a switch that activates some part of complex 1 that's not active. And that's why you see such a rapid effect. Carnitine is water soluble, it builds up in the body very quickly, and acid works in concert with carnitine to activate complex 1. So then we use antioxidants, as I already mentioned. Another way that has not been explored in KAT6A, which is very important in some of the mitochondrial diseases I treat, is stimulation of the NR2 pathway. I think someone here mentioned Epi-743. Is that?
Yeah.
Did you mention Epi-743?
Yes. Hudson has been on that for probably 4 years now.
Okay. And what did you see?
So he was admitted to that under the emergency treatment protocol, and we immediately saw an immune system reaction. Like, he used to be so sick constantly, multiple hospital admissions, and now, I mean, maybe one hospital admission a year. So definitely helped his immune system greatly. And we saw Dr. Inns at Stanford, and the very first thing he said when we came back after having been on it for 6 months was his attention span is so much better. He can focus on things now, to where before he was very chaotic and disorganized.
Okay. So these are, again, that's something that you speak for. The question is if you gave both carnosine, carnosine pantothenic acid and epi-743, would that have an additive effect? What epi-743 is, it sort of has an interesting history. They had found that gamma-tocotrienol stimulated what's called the NRF2 pathway, but you can't patent a natural compound. So the company that is making it engineered it so it had the same function, but they like stuck a method group on trienol, so it's called a drug. But I've been using gamma-tocotrienol for about 20 years in my patients, and it definitely can help. It doesn't help all mitochondrial problems. I just don't know the question right now of whether adding that in addition to carnosine. Is that on carnosine now or just the epi?
He's just on the epi. They made us get off of CoQ10 to get onto the trial. Yes. He could be on carnosine, but we were not.
So
he was on that for a long time.
All this data is very important. I'm not saying he should be on carnosine, but that's the kind of question. What I usually do clinically is I'll start a patient who has a mitochondrial problem on carnosine and the antioxidants. Sometimes if they're very sick, I'll throw in the gamma-tocotrienol for some time, and sometimes I'll add it later. This, I should say, is available over the counter or by email.
So I'm just wondering, my daughter has been told by several specialists that her levels are fine enough to not need any of this. However, that was once told to us by a GI doctor, and it was again told to us by a geneticist. So I'm just wondering, at what point does somebody make the final decision to say whether or not someone would truly benefit from the mitochondrial treatment?
It has to be evaluated. Most patients, just to give you an example, almost all patients in whom I make a diagnosis of mitochondrial autism, all the laboratory studies are normal. Because the values are not that increased. One has to use the ratio method to show that there is an abnormality. And then we can go on and confirm the abnormality by other means. But as a screening test, amino acids are very valuable, but the commercial laboratories, if it's within their normal range, which can be very broad, they just say it's normal. They don't recognize it. So it has to be evaluated by someone who knows mitochondrial function, not the GI doctor could, but in general they don't. So it's who is looking at the data to make sense of it. And simply saying that everything is in normal range, unfortunately, for diagnosing mitochondrial dysfunction, it just doesn't work. You have to have someone who knows mitochondria to interpret them.
I have a question about the B5. What does it do to just make the carnitine more effective? What is the role of B5? I know that it was on the other slide listed with it. Is it necessary to give that as well? Or?
I can show you how to go back to the beginning.
Sorry. I had a really hard time administering that to him.
Yeah, it is a, here it is. So, acetyl-CoA, when we work with, it's very common that when the mitochondria are being overworked, that they use up B vitamins more rapidly. And Barr syndrome, which I mentioned before, B6 is very often deficient. But it's enough to cause trouble, but it's not enough to be recognized as B6 deficiency per se. In fact, B6 deficiency usually leads to an increase in binding. Pancreatic acid is the source, is making acetyl-CoA here, or this is it. CoA is made from pancreatic acid, and therefore, to make sure that there is adequate pancreatic acid, we give our adequate coenzyme A, we give pancreatic acid. It also, studies have been shown, that unlike some vitamins, one can increase the level of acetyl-CoA, of CoA, simply by giving D5, giving pancreatic acid. Unfortunately, it's very hard to sort out what's helping, or if we give a cocktail to a patient, it's very hard sometimes to sort out what is doing what. And I'm reasonably convinced that in patients with classical mitochondrial disease, pancreatic acid can help. I don't know for sure for KAT6A, and if you're having trouble giving it, what I would do is give less of it. The daily requirement is 15 milligrams, and most of the patients are getting something like 50, and it can be irritating to the stomach. So if you simply give a multivitamin, which has 15 milligrams of pancreatic acid, that is enough to cover a deficiency, a secondary deficiency. It's not going to give the amount that we give mitochondrial patients, but I can tell you right now that it definitely is needed. So I would not be terribly concerned, as long as you're giving at least one daily requirement extra, that would probably be enough. I just wanted to show you what I'm working with now in terms of So I'm going to show you a summary of the amino acid data that we have so far.
Just a minute. No, here.
Okay. So this is the summary of the data that we have so far for KAT6A. It's about 20 patients. How many exactly? And it's not consistent. You don't always see abnormalities, but they're not the same in every child. And this may be because, as I explained, the whole interaction between KAT6A and mitochondria is related to diet. And therefore, the diet a child is on will influence the function of mitochondria, or the interaction of KAT6A with mitochondria. And that's very important. Diet is the main treatment for mitochondrial disease. And this is one of the things that we have to understand. What is the best diet for someone with KAT6A? So to show the most unusual findings are a high level of citrulline, which is here. And it's about half of the patients. Again, this is two standards. This is Z-score. So anything above about 1.25 is abnormal. So half of the patients at least have a high citrulline level. They also, a good number, have a high asparagine level as well, which is here, and some are quite high. They have high alanine levels, some of them. This is more characteristic of typical complex 1 deficiency type of mitochondrial dysfunction. They also have, again, to explain it, they have a relatively low level, as a group, have a low level of glycine. So there are many, all I can say is that there are many effects of KAT6A deficiency on mitochondrial function as manifested in the amino acids. We know that carnitine is helping. It may be helping not because it's changing any amino acids, but because it's stimulating production of acetyl-CoA, which then gets into the nucleus, which is where it is needed. These are all the things that we have to tease out. I've been working with this other condition, Barth syndrome, for more than 20 years. And fortunately, every few years we come up with something new. There are three main problems in Barth syndrome. One is a muscle problem and a heart problem. One is neutropenia, a low white blood cell count. And the other one is growth failure, or growth delay. And gradually, bit by bit, by studying the metabolism, studying the fatty acids, the amino acids, we've been able to figure out the cause of all three of those problems. And we've treated one, and we're pretty sure how to treat the other. But just to tell you, it takes a long time and to gather a lot of data. And fortunately, we now have a sufficient number of children to study that we can gather that kind of data. And it's a complex process for linking and eating answers. I should also say, each child is probably, as these show, each child is going to be somewhat different. So there's no one treatment that fits all for KAT6A. And that's been true for Barth syndrome and other mitochondrial problems. Even though the diagnosis can be the same genetically, the treatment is going to be affected by other genes that a child has. But we have these tools, these metabolic tools, looking at the link between nutrition and metabolism. And because KAT6A is a metabolic protein, it has metabolic interactions with acetone, which comes from mitochondria. That is what we need to do. I'll address one question right now and then open up to there's a severe, there are two problems with the GI tract in KAT6A. One is there's a high incidence of malformations, and this is evident, or a structural abnormality, because there are now 4 patients who have had intussusception, which is not a very common finding, and it's usually associated with dysmotility of a caused by structural abnormalities in the gut. It could be other causes, but this has to be the main thing. The other thing is that chronic constipation is a real problem in many mitochondrial problems. And what we have found in measuring citric acid cycle intermediates is that the level of citrate often is low. Now, unfortunately, I have not been able to measure that in KAT6A, but to go through a sequence, if citrate is low, if citrate is made by mitochondria. Mitochondria are working well, they make a lot of citrate. The same citrate that's in the citrus juice. That citrate is the only source of acetyl-CoA in certain types of cells. And that if acetyl-CoA and the primary neurotransmitter of the gut is acetylcholine. And therefore, if acetyl-CoA, and that's made from acetyl-CoA plus choline, if acetyl-CoA is low, then the gut doesn't work as well. And what we found in treating a number of children with mitochondrial problems, that simply giving citrate will increase the production, we presume, is increasing the production of acetylcholine for the gut, and the gut starts working. The first time I used this, if the child was on a drug that's not available anymore, Pitocin, because she had such severe constipation, she went once every several days. I put her on what I guessed would be, this first trial treatment, what I would guess would be the right amount of citrate. And I got a stat call from the floor saying that she's diarrhea. So we just backed off on the dose, and ever since then she's been fine. And I've done this in a number of patients. So-called, you may have read about pseudo-obstruction. In a typical mitochondrial disease, the primary cause of pseudo-obstruction is the deficiency of citrate. And we were able to show this by measuring the citrate in patients in their blood. And when it's low, they typically have constipation, it gives citrate, and the gut starts moving. But I want to say it's not going to be the cause of all constipation, but it's happened enough children with KAT6A have been put on citrate to believe that this is an option and needs to be explored. They're very specific. I've worked out now exactly what dosage one should start on and how much to increase to see when it's going to work. So, and of course it's not published yet, but it can be very effective, and it's much better than giving all these medications. It's quite natural. One interesting story, there's a boy who had autism, one officially, and very severe constipation. And before I started treating him, his father told me that they had to lock the refrigerator because he would go into the refrigerator, find a bottle of real lemon juice, and drink it down. And that's very high citrate. It's as high a citrate as the medication form. So he was treating himself. He really felt better when he drank that. And so just to show you that it's a very important aspect of certain monoclonal tolerance. So that's the environment.
No, it's fine. I just was trying to understand, are you saying that sometimes there's an actual physical issue with the intestines and sometimes it has to do with low citrate levels? And you're seeing both with KAT6A?
There's evidence of structure. There are structural elements in that. So that could be, for example, there could be in some other genetic conditions, the absence of nerves, there's a gap in the gut that has no nerve, or intussusception is often caused because there's a constriction or hematoma, a lump of extra tissue on the inside of the gut that serves as the starting point of this process. It's essentially what's happening. The gut is folding over on itself. And it's 4 patients now are regular tissue study who have that. And that's a pretty high instance to make you think there's something cats have had intussusception. And it's just not a common thing. And it could be due to constipation by itself, but most children that have severe constipation do not get